Here we go with internal medicine wrongs um, on June 18th, 2024. So first thing is telling the difference between leukemoid reaction and chronic myelogenous leukemia. So of course, the first thing you want to do is make sure that it's neutrophil heavy as opposed to lymphocytic heavy. If it was lymphocytic heavy, then you would be thinking more chronic lymphocytic leukemia. If the platelet count is high, that doesn't necessarily help you between CML and reactive leukocytosis or leukemoid reaction. The leukemoid reaction can be high platelets as well, but they're gonna have to tell you that there was some sort of sickness that preceded it within like the last month or so. And that illness can include a heart attack, which doesn't really feel like the thing that would work with leukemoid reaction, but just keep it in mind, it doesn't actually have to be like the flu or something. It can be even just a heart attack. Don't be afraid to pick no further eval in somebody with anemia of chronic disease. If they don't have any symptoms, they may be slightly anemic and have a microcytic anemia, and you just don't need to do anything for them. They also don't have to tell you that there's flank pain or hematuria or thrombocytopenia or like petechiae for somebody that has a positive Coombs test. So normally I would like to see like flank pain or some sort of better indicator that there's like actual hemolysis happening, but they're basically saying that the reasons that you would like the reasons why you would have a negative Coombs test are going to be things like MAHA, DIC, sickle cell disease, and G6PD, or hereditary spherocytosis. And if they're telling you that they just gave blood to somebody and it basically didn't work, you're supposed to just assume that it's a delayed hemolytic transfusion reaction. Normally happens 7 to 14 days after the blood's been given. If they tell you that it's squamous cell carcinoma, then that could be endobronchial obstruction. You know that squamous cell likes to go midline anyways, so it fits the mold just fine. Keep in mind if they use the term pulmonary parenchymal necrosis, they're probably talking about pulmonary effusion, or I'm sorry, pulmonary embolism causing that portion of the lung to not actually get any blood the way it's supposed to. For Crohn's disease, it is ineffective reabsorption of bile salts. That's what Crohn's is. It does happen most often in the terminal ileum, and it can just randomly happen in a 37-year-old. But if they're looking for like the buzzy word of it, they're looking for ineffective reabsorption of bile salts. That's really all there is to learn about. I mean, you just had to know that ileal inflammation can overwhelm the ability of the liver to synthesize de novo bile acids, which would result in deficiency of fat-soluble vitamin absorption. If they tell you that there is a random, like 30-something-year-old guy and he has left lateral face pain that is warm, tender, and erythematous, then that could be sialadenitis. So they're just saying that he has a salivary gland problem. I don't know, I guess we got this confused with temporal mandibular joint dysfunction because there was no like systemic infection. There was no cough, no tachy. The blood pressure was barely up. There's no temperature. There's nothing here to say that he has like any sort of systemic sickness, but it doesn't matter. Saying sialadenitis, the salivary gland infection, or irritation doesn't have to have those things. You can use an ultrasound or a CT to help establish that diagnosis. And a lot of the times, the treatment is conservative. You would use pain relievers, application of heat massage, and you would give them hydration. If it doesn't get any better there, then you can try and remove the stone, the sialolith. Sialolith. If they give you a patient that has recurrent pancreatitis, they are saying that they are going to have decreased insulin production, decreased glucagon production, and normal insulin response. I guess they are going to give you somebody who looks like they might be getting diabetes, but it's not diabetes. They have calcifications in the pancreas leading to pancreatic insufficiency. I don't know. I think we just didn't read this question, to tell you the truth. Okay, so nephrotic syndrome puts people at risk for DVTs. It doesn't actually like increase their odds for nephrolithiasis, but if they have anything about like having 2+ periorbital edema, 3+ pedal edema, even in a 23-year-old, she has all these swelling issues, and you've come to the conclusion that they have nephrotic syndrome, just keep in mind that they are at increased risk for deep venous thrombosis. They have a deficiency of antithrombin 3, which leads to hypercoagulability and puts the patient at higher risk for thrombotic conditions, such as DVTs. Keep in mind that another question they like to ask is, what are they at risk for? They're at risk for infections, and that is because they're going to have urinary loss of gamma globulins. There is a patient who has a brother with type 1 diabetes mellitus, and then the patient themselves ends up having a thyroid issue. So they are going to go ahead and say that the thing that puts them at highest risk for developing the thyroid issue is that relationship. This is just kind of maybe like nonsense. I guess you're supposed to just rule the other stuff out. Divalproex, oral contraceptive pills, and multivitamins don't cause hypothyroidism. I mean, that's fine, but there's a lot of drugs that do, and they don't give you examples of which ones that do. So, if there is a 32-year-old woman and she has loss of her period, amenorrhea, she has milky discharge from the nipples, galactorrhea, and she has an increased serum concentration of prolactin, then you can just go ahead and do an MRI of the pituitary gland. There's no need to get FSH, LH, mammogram, estradiol. None of those are more acceptable things to do for the next step in the diagnosis for that patient. You're just going to go ahead and get the MRI of the pituitary gland. Some patients might take dopamine antagonists like antipsychotics that increase those kind of concentrations that would cause amenorrhea and galactorrhea. But if they don't have any of those drugs in their regimen, then it's more likely that there's an autonomous secretion of prolactin from the anterior pituitary adenoma. Man, it is just really hard to not pick IV fluids every single time, and you really should, because even when they have toxic shock syndrome, which you knew because they had a macular rash over the face, trunk, hands, and feet with 1+ peripheral edema and a fever with diffuse muscle pain and bone pain, it sounded so much like toxic shock syndrome. They didn't even give you any weirdness about like having no tampon in forever, and still knew that it was toxic shock syndrome. But you gave them penicillin, and penicillin is not going to help them with this illness. They need fluids and presumably some sort of better antibiotic than that. They don't even tell you They just say that metronidazole and penicillin wouldn't have worked because most of these Staph aureus species are penicillinase equipped, so they would cleave the beta lactam ring of the penicillin molecule. Got one more. All right, so they give you a weird vignette about a study that's done between alcohol and cancer, and they're saying that the regular use of alcohol reduced the risk of colon cancer. So now they want to say, why is there a concern about the author's conclusion? And there's a lot of different things that can confound variables. You could have inappropriate selection of case or control groups. So they're saying that in this particular instance that you didn't pick the right control group. In this scenario, choosing a control population that consists of patients admitted to the hospital with different acute injuries interferes with the interpreted results of the studies that the regular use of alcohol reduced the risk of colon cancer. This is because regular alcohol use can lead to acute injuries during intoxication, and thus the control group may have a higher baseline use of alcohol compared to the case group. This likely led to the possible inappropriate conclusion that alcohol reduces the risk for colon cancer. So, I mean, I don't know. This is kind of a hard one. I don't really know what to make of it, but just know that if they tell you that it got age matched, both populations got age matched, it's probably not confounding.